Not so, not so. Okay, not bad. No, yeah. So I'll be trying to cover pharmacotherapy of ocular allergies. Now, before we start, I thought we'll start with how, when, why, and where. So what is an allergic reaction? So basically, it's a body's misguided reaction to a foreign substance. Now, usually it's trained to attack foreign pathogens, which are infective. But in this case, it's going after something that's relatively harmless. So why do we have such severe symptoms? Now, for that, you need to understand what actually goes on the ocular surface. Now, the conjunctiva has goblet cells, lymphocytes, Langerhans giant cells, macrophages, mast cells. But you do not see eosinophils on the conjunctival surface, at least in a normal conjunctiva. Apart from this, you also have conjunctival associated lymphoid tissue, which usually is biased towards a non-inflammatory immune state. So then the conundrum. So what is the lack of inflammation at the basal state? So what does that indicate? Does it mean that the immune response is absent? No. It just means that the regulatory mechanism is a lot more superior. So this is what is known as mucosal immune tolerance, which can be both innate and adaptive. Now these are all the interactions that appear on the mucosal surface. Don't worry, I'm not going to bore you with this slide. But what we really need to take away from that is the fact that you have histamine, you have T helper cells, and you have leukotrienes. Now histamine results in vasodilation, which is what you see as injection or redness. It increases the permeability of the blood vessels, which is what you see as chemosis. And also when it affects the nerve endings is when you have the typical itching that you see in allergic conjunctivitis. T helper cells, on the other hand, increase fibroblast proliferation, and this results in the formation of papillae. And lastly, leukotrienes stimulate the goblet cells, which is responsible for the discharge and mucoid discharge that you see in all the allergies that you have. Now, there are multiple pathways through which an allergy acts. So you have mast cells secreting histamine, you have cytokines, you have the cyclooxygenase pathways, you have the phospholipase. But at the end of the day, when you come to pharmacotherapy, we only have two drugs. We only have drugs targeting two things. We either have the mast cell stabilizers or the antihistamines. Steroids, of course, don't come under this because they sort of lower immunity as a whole. Now, apart from this, you also have other medications. You have cyclosporine A. The strength is important. You want to use the suspension form and not the solution form. You also have tacrolimus ointment, although it is poorly tolerated. You have oral and steroids and immunosuppressives as well. Now, we'll do case studies. So this is one patient. He's a young kid. He has severe vernal, as you can see. So seasonally, you start him on medications, he gets better, and then he stays quiet for a while, and then this happens. He starts with a shield ulcer. You treat him with steroids, he gets better, and then he develops one in the other eye. Now, the reason is not because it's happening at the level of the surface. The reason is sitting not there. This is when he actually developed a secondary infection again at the same site of the vernal. The reason for this is actually in the lids. It's because of this. You see, you have giant cobblestone papillae. Now, this is in both eyes. So unless you treat this, you're not going to get rid of that. So these are the cases in which pharmacotherapy will no longer help. You may have to resort to surgical management. So this is him after a papillectomy with a mucosal membrane graft. And this is how he looks after follow-up. These are, of course, the other side effects that you can have. This is keratoconus, which has come from the constant eye rubbing and gone into eye drops. So in this case, you treat him, you do compression sutures, he gets better, then you do a transplant for vision, and then this happens. You end up with transplant-related, suture-related infections because of the constant friction of the lids. You treat him again, he settles down. But then to what extent? These cases we've seen very commonly, but when you flip the lid, you again see these. These are cobblestone papillae. So that, and these are, of course, your plaque shield ulcers. So this begs the question, so what do you do in these cases? So these are cases where just pharmacotherapy will not be enough. You may have to resort to surgical adjuncts. Now, cryotherapy is all right, but it does induce a lot of scarring. You can also consider excision with mitomycin and AMT, but the go-to gold standard is a buccal mucous membrane graft. It is the most sturdy tissue that is available currently at the moment. Shield ulcers, of course, you can do a surgical debridement and excision, and you can also consider limbal stem cell transplants with AMT. Now, this is again a case study. So we had this 5-year-old girl who came to us in 2016. Parents very anxious. We started her on the usual, and then we advised an upper lid cryo in the beginning itself. Parents were hesitant, so they started her on oral steroids. She did not get better in 2017. Her steroids continue. She became dependent, and every time we weaned her off it, she started getting back on it. We sent her to an immunologist. They started her on cyclosporine. That didn't work as well because February 2018, she came back with a recurrence again. Out of desperation, we even sent her to a homeopathologist, but that didn't work, obviously. And finally, in May 2018, we ended up doing an upper lid mucous membrane graft. This is her 2 months before, so she's not had a recurrence since. So sometimes the pathology is a lot deeper, and unless you address it, you're not actually going to get the eye better. Now, I thought I'll also talk about certain other conditions that are ocular surface allergies but are not exactly ocular surface allergies. This is something which is quite interesting. So at night when you sleep, you have eyelid relaxation. So that in turn sort of, the eyelid closure causes a reduced oxygen exchange at the level of the corneal surface. You also have a decreased clearance of tears, and you have increased complement activation. And this in turn results in less corneal cell exfoliation. So you have a patient who will present to you with this. This is called morning eye congestion syndrome. Doctor, I get up in the morning and my eye is all red. So this condition does need steroids. This again, you see it in old age, you see it in a lot of our patients complaining of epiphora. This is tear stasis. Now, tear stasis, apart from managing the underlying cause, you also have to treat with ocular immunosuppressives because there is an inflammatory state happening in the surface of the eye. This is something we've all seen, staphylococcal immune disease. So basically it happens because there are toxins liberated by the bacteria that are colonizing the lid margins. Now, through the antibody response, you basically get a stromal infiltrate in the periphery that has a small lucid interval between it and the limbus. As this progresses, you have collagenases that come in and the neutrophils start to go in. The epithelium breaks down because there's no longer an underlying stroma. And then what happens later is that the tear film neutrophils start to perpetuate the disease. And then you have what is called this. If you let this progress later on, as the neutrophils continue downwards, you have a progressive stromal thinning, and you might end up with a corneal perforation. So in these cases, you start the patient early on a steroid, you actually get away without having to go through this process. This, of course, we all know is flectennular conjunctivitis, which will get better with topical steroids alone. You can consider topical cyclosporine in patients that are recalcitrant. This is, of course, contact lens-induced allergic immune keratitis. Once again, the treatment is a steroid. Now, this is something quite interesting. If you notice, this is the tear film, and this is a patient with acute viral conjunctivitis. You see these white turbid particulates in the tear film just next to the eyelash. So this is his history. He came to us having been seen for about a week outside. He was treated with a multitude of drugs. He was treated with steroids as well, but he just didn't get better, and the referring ophthalmologist said, I'm sending him over to us. This was him on day 1, extensive pseudomembrane, and he had a large epithelial defect, if you can make out. So just to recap, this is him. He was started on Predfort 6 times a day. On day 1, you can see that the surface start to stabilize. You can see the epithelium defect starting to get a little smaller. And on day 2, you start to see it heal. He, in fact, healed in 5 days. So these are some of the places where you must not hesitate to, in fact, use a steroid and not just treat him with antibiotics. So in conclusion, not all ocular surface allergies are just vernal. You can have a multitude or a plethora of phenomena. So your understanding of the pathophysiology actually helps in these cases and helps you also define management paradigms as they vary according to the underlying cause. And finally, like as everyone has said, the early recognition is very much important to avoid vision loss. So thank you for your time.
Thank you, Dr.